I'm excited to talk with you about cervical cancer because of the three we've talked about this afternoon so far, this is actually the most preventable. I'm less excited that we're running out of time, so I'm going to go fast, but I'll be around this afternoon to answer questions. Everybody in the room has heard of a pap smear. In looking at the audience, I'm going to guess most of you have had one. But what we're going to talk about this afternoon is not the same pap smear that your mother would have experienced. Not to belabor the point, but the cervix is kind of a setup for cancer because there's two different cell types. There's like skin kind of cells and there's glandular kind of cells, and the two are sort of battling for territory to simplify things as much as possible. But when that happens, that means the cells are turning over. They're more susceptible to genetic mutations, and as you've learned, genetic mutations cause cancer. So it sets the stage for the human papillomavirus to cause a cancer. So this is the causative, not just a risk factor, this is the causative agent of cervical cancer. So the other risk factors that we talk about are actually risk factors for getting the HPV infection or for not being able to fight it off. So other risk factors are age. The most common age is in your 40s, and then the risk actually declines thereafter. Other sexually transmitted infections, immune compromise, such as transplant patients who have suppressed immune systems or AIDS patients. Smoking, a lot of good reasons to quit smoking. This is really just one of them. And then oral contraceptives or birth control pills. And I want to be clear here because we've just heard very good evidence that birth control pills prevent ovarian cancer and prevent endometrial cancer. So I don't want anybody going home and stopping their pill, and I don't want anybody going home and telling their friends to stop their pill because they don't want to get cervical cancer, because there are much better ways to prevent cervical cancer, and the birth control pill has a lot of good health benefits in addition to preventing unwanted pregnancies. A little bit more about the HPV virus. This is the most commonly sexually transmitted infection in the United States. Probably on the order of 80 million women have been infected with the HPV virus at some time in their lifetime, maybe 15 million each year. Quick note that condoms may not be protective because while we're talking about cervical cancer, there are about 150 different HPV viruses, and maybe 30 of them like to live in human genitalia. Only about half of them have the capability of causing a cancer. But the bottom line is, while we're talking about cervical cancer, there are other parts of genitalia that may not be protected by condoms. And so condoms may not be protective of the virus. And then I just want to be clear, HPV infection is necessary to develop cervical cancer, but it's not the whole story. Okay, moving right along to this guy, George Papanicalou, who invented what we now know as the pap smear. It's a long story, but it all goes back to swabbing the vaginas of guinea pigs to help determine their menstrual cycle. That eventually turned into a test of swabbing a woman's vagina to help detect cervical cancer. It wasn't very popular at first because of what it took to get the test. But in 1948, I think it was, the American Cancer Society said this is a good test and we should do it. And so we did. And in the United States, implementation of cervical cancer screening with the use of the pap smear cut down cervical cancer death rates by about 70%. It's one of the most successful public health programs ever implemented in this country. But you may notice we hit a wall. So I'm going to tell you that in 2015, we still expect about 13,000 new cervical cancer patients in this country, and about 4,000 deaths from the cancer, which looks exactly like those stats from 2005. So why is that? Well, most women who present with cervical cancer never got any kind of cervical cancer screening or didn't get adequate cervical cancer screening. That being said, about 25% of them have had adequate testing and still wound up with cervical cancer. So obviously we have room for improvement on the test. Now, the pap test requires swabbing the cervix as depicted here. If those cells then go onto a slide, and then someone looks at the cells and tells us whether or not they're abnormal. If there's reason to believe there's an abnormality, then we have to go look at the cervix again with a colposcope, which is depicted here. It's kind of like a magnifying glass of the cervix. And if we see something abnormal, we biopsy it. in order to make the diagnosis of cervical dysplasia. Dysplasia is the precursor or pre-cancer for cervical cancer. On the left, you see normal cervical cells. On the right, you see cervical cancer. And the process of getting from the left to the right is dysplasia. The cells closer to the left, you see CIN1. That stands for cervical intraepithelial neoplasia, or new growth. Most of those will go back to normal on their own, probably about 80% of them. If they don't go back to normal, there's the opportunity to progress to higher grades of dysplasia and ultimately turn into the cancer. Now, I want to be clear that most women will be exposed to HPV in their lifetime, and most of those will clear the infection without ever having a problem. However, some of them will have a persistent infection, and then some of them will have progression all the way to cancer. Now, the other thing I want to point out is that the length of time between point A and point B here is on the order of years. It can take a decade for this to actually occur. These are just examples of abnormal pap smears. Obviously, by looking at this picture, you may guess that it requires an experienced set of eyes to make a diagnosis based on what kind of looks like colored tissue paper. So, one of the ways to improve the diagnostic accuracy of this test is to make it more objective. And that's when HPV testing came on the scene. Now, this became feasible in the 90s, and the first test was approved by the FDA in 1995. The process is the same. We still swab the cervix, and we use that material to look for DNA from the HPV virus. If we see it's present, then we know a little bit more about the patient's risk factor for there being a cervical abnormality. In 2012, the powers that be that write the recommendations for cervical cancer screening recommended something called co-testing for women aged 30 and older. Now, just to review the most current guidelines, which were written in 2012, but these are still the most current, cervical cancer screening should begin at the age of 21. No longer does it matter when a woman starts having intercourse. Age 21 to 29, the recommendation is for the pap smear alone, and if they're normal, every 3 years. Between the ages of 30 and 64, the recommendation is for both the pap smear and the HPV testing, hence the co-testing. And if both of those things are normal, then you can go 5 years without another test. But I want to be clear that there's a difference between how often you need your pap smear and how often you need your annual exam. Everybody needs an annual exam. Whether or not a pap smear occurs at that visit is a different story. The recommendation is also currently against doing HPV testing in a woman under the age of 30 because most of those women are going to clear the infection on their own, so detecting the virus isn't necessarily helpful. But if you do, and you do an intervention for it, then you could potentially be removing part of a young woman's cervix unnecessarily when her body might be able to take care of the situation on its own. And then finally, the recommendation is to stop screening at the age of 65, as long as the woman has never had an abnormal test and is at low risk. Okay, now you may have heard more about HPV testing in the press in the last year, and here's why. There are, I think, now 4 commercially available HPV tests. One of them, the makers of the COBIS test, have gotten the indication to use HPV testing as a primary screening tool, which means using HPV testing alone, not in conjunction with the pap smear. Again, from the woman's standpoint, it doesn't make a difference. You're in stirrups, there's a speculum, there's a swab of the cervix, but this is a different use of a tool that has been used for years now. And this is based on the clinical trial that enrolled 40,000 women. It was a huge trial. They all got HPV testing and pap smears and colposcopies, and they were able to improve the sensitivity of the test by using HPV testing first in women aged 25 and older. Now, I want to point out that they compared this to a hybrid, which included the use of both HPV testing and pap testing, versus pap testing alone. Now, this improvement in sensitivity was seen significantly in women aged 25. In other words, they found about 30% more cervical dysplasia in women by using this test compared to a pap test alone. If you looked at the cohort of women in this clinical trial who were aged 30 and above, this difference in sensitivity is no longer significant. So what that tells you is that you can detect more cervical dysplasia in young women, really young women under the age of 30, by doing HPV testing alone. But a few minutes ago, I told you that a young woman may clear the HPV virus on its own. So are we doing unnecessary procedures by doing this? Well, that we don't know yet, because these data were just published a couple of months ago. So that story will continue to be told. We do know that it took twice as many colposcopies in order to get this information. And if you're doing twice as many colposcopies, you're doing twice as many procedures, which goes back to the, are you removing part of a cervix of a young woman without necessarily preventing a cancer? Which is why this has not been recommended yet. However, the same people who write the guidelines published a paper a couple of months ago saying this is a reasonable option for women aged 25. You have to be careful because only one of the commercially available HPV tests is approved for use for this reason. So not every facility is going to use that test, and we don't know if it's safe or reasonable to use the other commercially available tests, so you have to discuss that with your physician. Okay, I'm going to switch gears to the HPV vaccine, which is our best tool to prevent all of this. The most popular vaccines vaccinate against HPV 16 and 18. So I told you there's 150 subtypes. 16 and 18 together cause about 70% of cervical cancer. So in the United States, that's where the money is in prevention. The Gardasil is the quadrivalent vaccine. That's the one that protects against 4 different subtypes. The other 2 are 6 and 11, which do not cause cancer, but do cause genital warts. And then there's a brand new HPV vaccine that just received approval from the FDA in December of 2014 and was just recently included in the vaccination guidelines. And that protects against 9 different HPV subtypes, so that an additional 5 subtypes provides an additional coverage for 20% more cervical cancer. So in theory, 90% of cervical cancer can be prevented by using the HPV vaccine. Now, in countries that have implemented this across the country, they've been able to demonstrate a decrease in cervical dysplasia by implementation. And in our country, the recommendation is for vaccination for girls and boys aged 11 to 12 years. The key to making this successful is being vaccinated before someone is ever exposed to the virus. There's a catch-up vaccine for those who aren't vaccinated between the age of 11 and 12 up to the age of 26 for women and 21 for men. It does require 3 doses over 6 months, and you have to continue your screening. This doesn't get you out of the pap smears or the HPV testing. Now, I mentioned that other countries have been very successful in decreasing the rate of cervical dysplasia with this. Our country, however, even though it was invented here, is not all that enthusiastic about using it for reasons that are unclear. However, as of 2012, only 33% of girls aged 13 to 17 had completed the vaccine series. So that was thought to be because mothers may not want to vaccinate their children for a sexually transmitted infection. But these are data from adults aged 18 and 26 who had the decision-making power on their own, and the uptake isn't any better. Varies a little bit by region. It's best in the Northeast, but still at 40%. Worse in the South, just over 30%. There are side effects because it's an injection, and 85 to 90% of people report some kind of site reaction. The reaction is a little bit worse for the new nonavalent vaccine because there are more viral particles in it. Not more severe, just more people reporting it. But no one's died from the vaccine. So when we think about new directions to take in prevention, diagnosis, and treatment, I put this back up here to remind ourselves of the spectrum of things that can happen. We can either prevent the problem with either better vaccination programs or better vaccines that don't require needles, more education, screening and diagnosis. What if we could collect cervical cells without using a speculum? Or what if we could diagnose cervical dysplasia without taking a biopsy? Wouldn't that be nice? There are therapeutic vaccines in development. None of them have been successful so far, but that's one tool people are thinking about. And then the bottom line is none of this works if we don't use it. So screening is successful if you use it. The vaccine is successful if you use it. And quit smoking. That's just a general good advice. Okay, and that concludes my portion.